Thanks, Bharat. And I'll be talking about cataract surgery in oil-filled eyes. Uh, I don't have any financial interest. Uh, we know that cataract formation is a common complication of partial vitrectomy, and as the vitrectomy is increasing day by day because of the improved technology, the surgery will also increase in these vitrectomized eyes. There are various factors responsible, like intraocular gas, or use of silicone oil, or direct instrument touch, then progression of senile cataract. Most of these are diabetics. They undergo VR surgery. There's progression of cataract, and there are a combination of factors. And there are various challenges when you're doing phaco and oil-filled eyes, like there's high risk of complication due to residual effect of previous surgery. There's increased risk of post-op inflammation. There can be emulsified oil in anterior chamber. There can be presence of posterior capsular plaque, or there can be presence of pre-existing posterior capsular defect. And since all these procedures, the vitreoretinal procedures, are lengthy procedures, so there is risk of damage to zonules, and that has its own problems in terms of loose capsular bag and other issues. Then there are some other challenges like fluctuating anterior chamber depth caused by increased movement of the lens iris diaphragm due to lack of vitreous support. There's infusion deviation syndrome that has been reported in these cases. Fluid migrates posteriorly, you raise the bottle height, further pressure increases, fluid further goes posteriorly, and then what happens is that the chamber starts becoming shallower, there's risk of iris prolapse. So all these things can be taken care of if we plan our surgery nicely. We should figure out the posterior capsular status preoperatively. We should delay surgery if the cataract formation is rapid, because if somebody has undergone vitreoretinal procedure and there was a sudden increase in cataract formation, sudden cataractogenesis and progression, this means that there is a posterior capsular defect due to the instruments. And so you should delay the surgery so that the margins get rigid, the margins of the posterior capsular defect, they become fibrosed, and then the risk of nucleus falling behind is lessened. Then one should use viscoat during surgery. It helps in coating the zonules because there can be some zonal defect because of the prolonged surgery. And one should use a low setting as far as the procedure is concerned. Apart from all these, as you can see here, this is an oil-filled eye wherein the cataract surgery, the routine chopping technique is done. Then you can have posterior capsular plaque, and if you see that it's in the mid periphery and there is no cleavage plane being created, then it's better to leave it like that. I prefer putting endocapsular ring in most of these cases of these vitreoretinal surgeries because of the chances of some degree of zonular damage in these cases. Now, as you can see here, this is another case wherein the posterior capsular plaque is there. There's a nice thick posterior capsular plaque, and you can create a cleavage plane. So once you have a cleavage plane, then you can lift these plaques and remove and clear the visual axis completely. But there are situations wherein you can have a large plaque which is actually, merging with the posterior capsule. As you can see here, there is a large plaque, but it's actually the posterior capsule that is opacified. So in such a case, and you can see the capsule is so taut because of the silicone oil that is filled inside. So it's not advisable to do a posterior capsular opening here because the oil will come into the anterior chamber, the whole procedure will become messy, and even the posterior capsular defect can extend peripherally. So in such a case, it is always advisable to remove this posterior capsular opacification while doing the silicone oil removal. You can put the intraocular lens, and subsequently, once the oil is being removed, then it can be done. Now, this is another case wherein you have a pre-existing defect, damage due to the instrument, but it was an oil-filled eye. Normally, if it's a fluid-filled eye and you have a damage in the posterior capsule, then there is a fast progression of cataract and the cataract becomes total. But if it's an oil-filled eye, what happens because of the meniscus that is there, closing the posterior capsular defect, there is no fluid that enters into the lens, and that is why perhaps the progression of the cataract is not that fast. So as you remove the cataract, oil will keep coming. So in such a case, I prefer putting a multi-piece IOL. And do an optic capture So multi-piece IOL, haptic in the sulcus, and optic capture. Once you have done the optic capture, then what happens that it closes, it seals the posterior capsular defect also, and there is no oil that keeps coming into the anterior chamber. Then you can have oil in the anterior chamber in all these eyes, so you have to remove the oil, and then you can go ahead and perform the procedure. Femtosecond laser surgery is very much feasible in cases of operated VRs. In this case, you can do a femtosecond laser procedure easily because there's no oil in anterior chamber. But if you have an oil in anterior chamber, then in that case, because of shadow, it doesn't cut the capsule properly, and it doesn't even emulsify. It doesn't even cause the nuclear fragments. But you can go ahead and do a femto procedure if you have oil or synechia in the anterior chamber, because these days, although I don't advocate, I would prefer doing a manual procedure in this case. But if some patient comes to you, after reading in internet and he wants a femtosecond procedure, then in that case, you can remove the oil, release the synechia, inject high viscosity viscoelastic, and then after that, you can go ahead and complete the femtosecond procedure and like this. The only thing is that if you have injected high viscosity viscoelastic in an anterior chamber, then in that case, you have to use higher energy for the procedure because of the high viscosity viscoelastic. So and in such cases, there is always the chance of skip areas. So you should stain the capsule and then complete the procedure. We performed a study comparing flax versus conventional phacoemulsification in oil-filled eye, and the rational study was that, as I said, that there's a risk of compromised zonules and loose capsular bag in most of these cases. So whether flax will have a better outcome in comparison to femtosecond laser, and we found out that the cumulative dissipated energy was significantly lesser in flax group, and the specular count again. The endothelial cell loss was also significantly lesser in flax group. As far as the total duration of the procedure is concerned, the flax group definitely entails 2 procedures, so it had a longer time. However, the phaco time in the flax group versus, that is step 2 of flax versus conventional, the procedure was faster in flax group in comparison to conventional group. And in 40% of eyes wherein there was no oil in anterior chamber, some oil came, a little droplet came into anterior chamber while doing rhexis or while entering into anterior chamber when performing conventional procedure. But since the flax is a closed chamber procedure, so none of these droplets came into anterior chamber. And as we know that, oil droplets coming into anterior chamber, touching the endothelium may have some implications as far as the endothelial cells are concerned. So there are, in conclusion, there are various issues that I would like to highlight in cataract surgery in oil-filled eyes. There are 4 major issues. One is there is presence of plaque, so you have to decide about the management of the plaque. There can be pre-existing defect, that is important. So you have to be careful in timing your cataract surgery. There can be zonular dehiscence because of the prolonged VR procedure, and then you have to be ready with all your gadgets to strengthen the capsule, to strengthen the zonules. And of course, there is risk of infusion deviation, so you have to keep a low setting, and you have to be really careful that if the chamber is becoming shallow, don't keep increasing the parameters. It requires a very good preoperative planning and accurate IL power calculation and a meticulous intraoperative manipulation. So thank you very much for your patient listening. I'm ready for any question.